want to say welcome to everybody who is here, ready to go. It sounds like there's already some excitement for the topic, which is, we're going to be covering methamphetamine in various different versions of it. So there's no echo. Thank you, Elle, I think, for verifying that. But also, before I say all that, for any of the United States viewers that we have right now over here, it is Mother's Day. So happy Mother's Day to any of the mothers who have ever stood by you, helped you, guided you, taught you anything. Some of us have good relationships with moms and some people don't. I think a mom can also be any maternal figure, any type of person that provides any nurturing and care. Sometimes it doesn't come in as the role of the mom, it could be someone else, but there's a lot of value in that role in everyone's life. Some people don't find that till later on in life, but I know I have a positive relationship with my mom. Happy Mother's Day, Mom. I know you're watching this, and I'm looking forward to hearing and getting to know people, and hopefully having a lot of people jump on today and utilize this opportunity with Dr. B and I to be able to dive into the roots and address your questions. So really excited for this. Ready to do it, Doc.
Yeah, likewise. And, after we came up with this topic, we thought maybe since it's Mother's Day, we should have done a topic with mothers, but we can kind of start to encroach on that if it comes up. Parham, give me some thoughts, your thoughts on this issue as far as, I guess, we're just doing methamphetamines. I want to really reduce this issue to a particular, so there's no confusion and so forth. We're doing methamphetamines, right? That's what we're going to keep the topic on. Okay, give me your thoughts.
Well, I can share with you guys on the clinical side and the psychosocial side and how it impacts human behavior and what usually the reports of meth users are in regards to the relationship with that drug, the positive effects that they seek to find from that drug, some of the negative consequences and the withdrawals of that drug when it comes to on the psychological and emotional level. So I'll gladly do that. So for those of you watching, I'm a licensed advanced alcohol and drug counselor. I have a master's degree in marriage and family therapy. Personally, I've also been, in recovery for the past 13 years. So it's been 13 years abstaining from all drugs and alcohol. So I have a lot of personal experience. I have a lot of professional experience, and I've been in the field for over a decade. So it's safe to say that I have a firsthand and intimate view of methamphetamines and the impact that it has on the various users. And in the United States, at least here, I mean, I can't speak for the whole world, but the United States, there are pockets of our country that is riddled with methamphetamines. I mean, when I talk about riddled, it's to the point that everyone says meth is everywhere. Everyone is on meth. And I know that's a skewed perspective, but there is a lot of meth use that's happening. And it often happens from a really, really young age, man. It happens from a really young age. There's ease of access to it, and it's the impact that it has is significant. So some of the things that I see clinically with people that have been using or abusing methamphetamines for a long period of time is the impact that it has on the dopamine receptors and the impact that it has on the individual's inability to experience pleasure from things that provide pleasure, that produce pleasure, and which leads to this stage of depression, which leads to anhedonia, depression. It leads to the inability to get motivated in life, to be inspired in life. And it's like this perpetual cycle that without the drug, they have a hard time getting out of bed to even function. And I know that's a lot of that's a precedent that happens in a lot of addictions, but meth, because of the amount of energy that gets created for the user and the amount of dopamine that gets produced, it becomes something that they're using just for normal functioning. And when they come to treatment, when an individual says, hey, there's too many consequences as a result of my meth use and I need help for this drug. When they come to treatment and they get off the methamphetamines, now they're faced with a pretty big challenge that I've seen. A meth user that's getting clean and sober, we'll use that word. I know sometimes we don't use it here, but when a meth user is getting clean and sober off that drug, they have a hard time with doing the regular daily livings, right? The activities of daily living because of the amount of depression they're in. Sometimes there's things that I've seen like delayed psychosis. I'm not talking about a meth-induced psychosis. I'm talking about a psychosis that happens weeks, sometimes even a few weeks, maybe even a month later. I've seen people have a hard time with experiencing any type of motivation to go to therapy, motivation to sit in group, motivation to get up out of bed. I've seen people crash for 15, 20, 24, 48 hours straight after a meth run. So there's a lot of barriers that happen with the discontinuation of meth, and also with the ability to kind of accept the treatment that's offered and provided. And usually meth users, their world back home is full of the same, birds of a feather flock together. They have a hard time creating a new world, a new identity that is far removed from their drug of choice, which is methamphetamines. They have a hard time creating a life, a lifestyle, an identity that's new, that's not rooted in the past. And I would look forward to hearing a lot about people that are, what they have to say. But I do hear a little bit of an echo going on here for me too, doctor. So I don't know. I'm trying to see what it is on my side.
Go ahead.
Yeah, but feel free, Doc. Go. I'm going to troubleshoot while you talk a little bit right now.
Sure. I'll give some background, and some of the data that I have, unfortunately, covers all stimulants. But the numbers fluctuate, and they're a little difficult sometimes to interpret. You will hear methamphetamine use has gone down in the last few years. I'm going to argue that it has not, and it is extremely endemic in certain areas and populations. Just for the sake of getting everyone to understand the impact at a macro level, some data from 2018. Now, keep in mind, although we're going to talk about methamphetamines, this is stimulants, some of the data. In 2018, I think about 28,000 overdoses were attributable to stimulant use. Okay, that's 40% of all overdose deaths in the United States. Stimulant-related offenses, of all federal drug offenses, they're 75%. Okay, they accounted for more than 75% of all federal drug offenses. Okay, that's insane. Okay, amphetamine-related hospital costs total way over 400 million, this was actually in the early 2000s. Over 400 million today. Just so we understand the impact of the problem is escalating. It's well over 2 billion. And this number is just a few years old. I can't recall 2000. It's well over 2 billion. So that's the general societal impact, if anyone thinks it is decreasing. Between 2007 and 8 and 2015, 16, amphetamine-related hospitalizations more than, I think, triple. Okay, and as of 2019, I have this data for methamphetamines. Okay, it has surpassed opiates as the leading cause of overdose death in many Western United States states. Okay, short-term individual impact. Okay, and this applies to a lot of stimulants in general, and it varies on many factors depending on the combination of use, route of use, route of administration, potency, dosage, level of prior use. Well, so a lot of this is in general, but in broad terms, we can say methamphetamines increase alertness, reduce appetite, give people usually the intended feeling of euphoria. And the three main transmitters involved are dopamine, serotonin, and norepinephrine. Okay, and I want to point this out. Everyone thinks of dopamine as for opiates, right? It increases your dopamine in the nucleus accumbens. Stimulants, methamphetamines, have a much larger dopamine rush in the brain than opiates do, by far. Number two, just so everyone knows, the concept, the clinical construct of psychosis, paranoia, all those things, those are huge overloads of dopamine, that very thing you need at a normal level to function, depression, all that stuff. So these are all dopamine issues, okay? So the adverse effects of methamphetamines are well documented as they are for many, many stimulants. The peripheral effects are increased heart rate, vasoconstriction. That means your blood levels, your blood vessels really, really shrink extensively. And this is the autonomic peripheral nervous system events that happen. You get bronchodilation, okay, you can breathe better. But all of this has severe stress on your cardiovascular system, okay? And it can also increase elevated body temperature. And what this hyperthermia, and what this sets up you up for in an acute situation is cardiovascular events. Now, people think of that sometimes as heart attacks. Well, let me put it in really simple terms. You can also have a gut attack. You can have a brain attack, which is strokes, whether it's bleeding or clots. And it's quite extensive. In addition, acutely, this stuff can have very extensive adverse psychological effects. Acutely, again, I'm talking acutely right now, and neurological effects, panic attacks, hostility, paranoia, psychosis, violent behavior, which really comes into the issue of how people make really poor impulsive decisions. On a more chronic long-term effect of this stuff, and some of it leans over from the acute attack, using this stuff increases your chances of getting HIV, getting hepatitis C, acutely and long term. Why? Because you become more impulsive, your risky behavior increases, and again, on a more long term level, you're increasing risk of angina, heart issues, valvular disease, which is heart issues. You see people having to get transplants with endocarditis, cardiac failure, stroke, all of that stuff. In addition, there's extensive literature and data of impaired cognitive, neurological, and emotional dysfunction because, remember, stimulant use releases large amounts of dopamine, serotonin, and norepinephrine, okay? And this can lead to mood fluctuations, anxiety, depression, even when not taking the drug if you're chronically using. In addition, your neurocognitive outcomes seem to have a battered continued effect. And I pointed this out somewhere where it is no different than taking a bat to somebody's head. And we have pretty good evidence at the extremely way down cellular level. This stuff is basically equivalent to traumatic brain injury, the way cell death happens. And many researchers have looked at utilizing brain injury rehabilitation for chronic methamphetamine users. This doesn't affect everybody, but all of that, okay? And finally, I want to point one last time about societal effects, the negative outcomes for the children involved with the parents that use this stuff. Heightened crime in the communities, okay? Cost associated with enforcement, incarceration, environmental damage of the many amphetamine local labs that I have had to deal with because of the area I used to practice as a emergency medicine physician. The environmental damage and the premature deaths, these are costs that are very difficult to measure. In addition, stimulant use by pregnant mothers, okay, can have long-term health and development effects on the children, delayed motor development, poor language skills, cognitive, behavioral skills, and this is quite little questionable, but kids coming out premature and all that stuff. So it's a big deal, guys. Okay, I sorry I went a little too much into it. It's a big deal. Don't underestimate it. And one last piece. In fact, this month on my YouTube, I have my deep dive into stimulant use. I have started with synthetics and new psychoactive substances, as one of the terms are, or designer drugs. And very soon I'm going to veer into amphetamines and methamphetamines and get into all of these issues. And so that's my thought on this, including treatment and what we're looking at on the horizon in terms of xenobiotics, pharmaceuticals for treatment.
Man, doctor, that was some good stuff. I've been around this world for a long time now, and whenever you speak, because the way you talk about a certain, we'll call it a problem, but you call about a certain identified topic, and you're able to circle around and look at it from a 360 point of view and look at it from a bird's eye point of view. It's really, really fascinating, man. It really is. The fact that you cover every angle. And I do think, are you sure you don't have something on your computer from like a YouTube or something?
Let me try it.
Because I feel like I'm echoing somewhere.
Let me turn this off. There's a YouTube, but it has to do with Microsoft 365. Let me look somewhere else. No, were you able to get rid of it?
Let me see if I keep talking, because if I keep echoing, I could just take off my camera. But I think I'm still echoing, which is weird. Okay.
If it's inhibiting you, you can go off and come back on.
Yeah, let me. I'm just gonna connect my regular microphone.
Sure. No, do your thing, man. Hey,
when I speak now, but can you hear me well now?
Keep talking.
If I speak right now, and anybody else, by the way, if you're watching, just let me know if the echo went away. It might have been my microphone maybe today.
Sounds great. I got some people coming on TikTok. Hey, guys, go if you're coming on a usual announcement, go over on our YouTube channel, ask your questions. The generating topic today with me and Parham Nematola is methamphetamines. We're going to discuss that a little bit. I think we're also going to discuss some of the treatments, and we are here. Get on, let us answer your questions, and that's for TikTok. Okay. Yeah, go ahead. Thank you, Parham. I appreciate the feedback. And I'm always still learning myself, but I appreciate that.
And there's one more population we didn't talk about with methamphetamines is also we talked a few weeks ago, if you remember, we did something on sex trafficking. The sex industry is riddled with methamphetamine use and that whole subculture within that. Now it's something that I've seen firsthand. I've worked with human beings that come through those systems, and it's something that is used very frequently with a high level of intensity, and it is riddled in that community also.
And in fact, I'm glad you brought that up. It is very riddled in that community, which is just a compounding effect of crap. But one of my team members that works with us, she was going to do this, and we're going to get back to it. Homeless woman, right? Homeless substance abuse females are just homeless females. I don't think anyone's ever looked at this. If there's somebody out there that's looking into coming up with a PhD thesis in different areas, and I have to give credit of this idea to Carol Newark, but she brought it up and we discussed it. One of the things somebody could look at is the use of methamphetamines by homeless, marginalized females so they can stay awake for safety purposes, right? And so yeah. Can you imagine the compounding effect all around of this crap? But and there's so many different populations that we probably haven't even touched yet. But yes, absolutely, you are completely right on that. Let's talk about a little bit about treatment, Parham. Yeah, and you're actually the perfect person for this because to this day, I cannot discuss certainly not maintenance medication, but pharmaceuticals that work. So my hands in that area of what I do are tied. And the data, and I'll go over some of it, is extremely clear that what you guys do is the way to go to get any outcomes. That being said, there's much that I can do on my end, but it really ties in into relationships and harm reduction approaches with your patients or clients. So please educate us on your thoughts, your experience at your center, and what you can give us.
Absolutely. So when someone comes in with a methamphetamines addiction, now it doesn't really matter what route of administration they're using. When meth is their drug of choice and it's what they choose to use, for me, I never look at the ending of where they're at, and I always look at the beginning, right? So when you do a little biopsychosocial history of a methamphetamine user, and this isn't in all cases, so this is not something that I could say happens everywhere, but in most cases, you look back at their childhood and you're able to identify some type of, whether it's trauma, some type of chaos within the home, some type of an environment that they were unable to focus in and tune into and pay attention to. Therefore, in order to cope with that volatile environment, they were forced to check out at a time that they were supposed to be checking in. So they were forced to check out for a coping mechanism because maybe mom and dad were yelling too loud or there's some chaos going on in the house, and they check out to be able to manage their emotions. But that's happening at a time in their life that their brain is developing in a moment by moment by moment interaction with the environment. So when they do need to focus and pay attention, they're often unable to focus when they need to. And these children get identified primarily in school, in the education system. The teachers having a hard time having them sit down and focus in class. So someone with limited to minimal experience and understanding of clinical, what's going on in terms of family system says, hey, come to school. We're thinking about giving a referral for this kid to go check out for his ADHD, where we're assuming he has. And majority of meth users at some point in their life, they were placed, and I know this is a reach, and this is no data behind this, guys, but this is just observation. Doctor calls it anecdotal, but it's what I've seen enough to see that there's a pattern, that there was some type of a Ritalin, some type of a Vyvanse, some type of a Concerta, some type of an Adderall that they started to take at a young age, not really to deal with what was their symptomology, but to deal with what was going on underneath. What was going on in this person's life that they were unable to pay attention, that they were so depressed they couldn't get out of bed, that they didn't have the energy to talk and move around and joke around with their cohorts and their classmates. And later on in life, and a lot of them, by the way, report that they have a bad experience with that medication. A lot of kids say they don't like taking it. They don't like the way it makes them feel at first. It makes them feel like they lose their personality. However, I guess the plant's been seeded at that point. And later on in life, when they become teenagers and they become, adolescents, they start to experiment. Maybe they're already smoking some pot and they start to experiment with methamphetamines. And all of a sudden it does something for them that it may not do for somebody else. And what it does for them is they're all of a sudden able to connect with other people. They're able to talk. They're able to focus. They're able to laugh. They're able to engage. They're able to stay up at night and just kind of be productive. They're able to make friends, and feel a part of society. It does magic for them. So then they go on this pursuit of using this drug to feel normal, right? They feel normal. They use the drug to feel normal. And like we know with all addictions, there's going to be serious physical, psychological, emotional, societal, spiritual consequences. When those consequences start to, in relationships get significantly impacted with methamphetamine use, especially when both individuals are using together. I mean, it's like fuel for fire. But what happens is then they seek treatment. Like I said earlier, they come to treatment because they need to discontinue the use of this drug. And now they're sitting in a treatment center. So a clinician needs to do a full biopsychosocial assessment to understand the history of use, why this person is using, what are they getting out of this drug? What's the payoff, right? Why do they keep using this drug despite of negative consequences? Obviously, they're getting something out of it. There's something that they're looking for. There's something they're seeking. And the goal of treatment becomes to replace what it is they're getting from the drug with safer, alternative, healthier ways, right? If methamphetamines is helping them focus in life, what can we create? What can we develop? What can we establish? What coping skills, tools can this human being include into their life that helps them focus? What can we do that helps them be able to calm down their mind a little bit, to quiet their mind a little bit. That, by the way, it does that with methamphetamines use. I know we think that they get all riled up and they keep going and going and going. If you talk to someone that's a true meth addict, they'll tell you that when I use, that sometimes my mind quiets, right? Later on, when they use too much, then it's when the mind starts racing and psychosis and all that kind of stuff happens because of dopamine. But it becomes, the importance of it is be able to how to ground these human beings, how to bring them back to their breath, how to bring them into the body, how to bring them into a level of comfort. Because here's the thing, you have to do all that, and guess why? Because then you have to reverse the steps back and go back and find out the root of that trauma, to find out where it all originated at, this underlying causes that everyone talks about and nobody addresses. You got to get to the underlying causes and the roots of the meth addiction. Because if you don't resolve that, if you don't look at that, if you don't heal from that, all of a sudden that next drink or that next drug or that next high is going to be right around the corner, and it leads you back to the same cycle. So a true treatment for methamphetamines, I mean, there's some evidence-based stuff out there. The matrix model for stimulant use is an evidence-based treatment that's outpatient level of care for methamphetamines. For the trauma component of it, EMDR works pretty well, once the person's stabilized. And when I say work really well, I'm talking in general, data and numbers. But yeah, you just got to find a way to be able to help the person connect to themselves, because they've been so disconnected for so long. I mean, if you ever have a chance to watch the documentary of Faces of Meth, just go Google Faces of Meth, and you watch these beautiful, pure soul human beings get arrested for the first time, and they follow them through all of their arrests, all their mugshots over the course of their arrest. And you look at picture number one, which is just this person that looks like they're in a lot of psychological, emotional, physical pain. And you look at their last pictures and you watch what methamphetamines does to the human soul and the spirit. It breaks them, right? So this person, when they stop using methamphetamines, they have to go back that whole journey, and they got to heal from that. There's a lot of healing that goes on from the meth world. Yeah, Doc, I know that's not a too specific answer, but if somebody jumps on and they want to talk to us about, recovery from methamphetamines and how to go about it, we can get a little bit more specific.
Yeah, no, I'm gonna push you on getting more specific, and that was a fantastic answer. But unfortunately, I think due to time and so much of we could each cover, you're trying to capture really, really nuggets and something that applies to everybody. I want to bring you and ask you, and then I'll chime in on this issue myself, because I do have something to say. During the initial stages, with major cravings going on, and really getting the brain to restructure itself in terms of architecture, and getting those neurotransmitters at a normal level, and getting them through the initial phases of, I don't like this word detox, but we'll just say early phases of recovery. That's the better term for this. From a mental health perspective, how difficult is it, and how do you approach engaging that person because what you're talking about is very high cognitive outcomes, which you are right, that is the root of it. But from that initial attempt at recovery from methamphetamines to getting to where you are saying, my thought has always been this is a long stretch, and you need a really good person that you're working with, and it could take a long time, potentially really a lifetime, long when you're past stopping methamphetamine use. And you described that beautifully, but as you know, we are limited by the structure of our social framework and constructs, including insurances, the systems, institutions, people's biases, perceptions, understanding of what the kind of work it takes. How do you approach it? Because I know you have a very successful and reputable treatment center that you work out of, and you're part owner of all of that. But I think the benefit of them is having you in dealing with others. So, give me me some feedback on that and on those early stages.
Actually, those early stages are probably the most important stages, everyone. Just for the brain to recover from stimulant use of methamphetamines. And doctor, you probably know this better, but the number that I've heard is 18 months. I've heard 18 months it takes for the brain to start to heal and recover, so, and I know that could be even a lifetime, but that's like the minimum that I've heard. So this isn't something that I'm saying right away, 10 days into detox, you're getting into this stuff. But my best suggestion, I know I'm going to go very, very, very basic here, and this is actually something we do apply, so I'm not just making this up. I like to get to the most basic forms of healing. Number one is rest. I legitimately mean that, is rest, because methamphetamine use does a number on the way the biological clock works. It does a number on the way people stay awake and go to sleep. People pass out standing. I mean, they're up for 3-4 days at a time without getting adequate rest. In the beginning of the treatment of getting off methamphetamines, you're bound to repeat the cycle again. Like if you get too tired, if you stay up too late at night, if you're not being productive throughout the day, not resting the way you need to rest, the meth use is right around the corner. I'm reading the side chat. Some people are saying we use meth for energy because our kids are awake all the time, that kind of stuff. So it's significantly used for that. The next one is hydration. You have to be hydrated, not just meth. I mean, meth does a number on stimulants, does a number on dehydration, right? It really does. But hydration is so important. The next one that I have always is movement. And the reason I say movement is because it forces the brain to start trying its best to produce dopamine, which methamphetamines uses. It drains the heck out of all these neurotransmitters, serotonin, dopamine, norepinephrine, the stuff you're talking about. The dopamine, when you get around and walk around the block, just 30 minutes, walk around the block for 30 minutes, five times a week, 7 days a week, and start to feel a little bit better. If you move the body, the mind will follow. Flex a muscle, change a thought. These things are there for a reason. You can actually change the way you feel by the way that you move your body. The one after that we have is sunshine. I know some places you might not be able to get sunshine, but get sunshine into your soul, into your spirit, because meth is a lot of weird late nights. It's a lot of doing stuff on your own. It's a lot of indoor stuff. You need to get the opposite of that. Next one is connection, is human connection. So sometimes just sitting in a room without methamphetamines and being able to connect to another human being for the first time, void of the drug, just connect to a person, just talk to a person about how you're feeling, how you're doing, what you're up to, what challenges you're experiencing. And I know the answer to that was, we think about meth addiction as being something so complex. And I'm saying that the solution in the early stages is the most basic forms of human healing. There is truth to that, because sometimes we forget that. We think that in order to feel better, you have to do all these complex things, when sometimes you just have to rest and relax. What is that? The most common prescription prescribed in the world is rest and relaxation. Maybe not the United States, but in the most of the world, it's rest and relaxation, because there is some value to that. And yeah, so that I know that's as basic as I can get right there, Doc. It's the basics. You got to keep it simple.
Yeah, this is great. I'm gonna give you my 2 cents on it.
Yeah, for sure, man.
My approach, and I agree with everything you say. Just so people know, again, a mental health approach even reduces the risk of eventual development of psychosis, which over 40% of chronic methamphetamine users will have at some point in their life. It even reduces the risk of that, and that's how important a mental health approach is. Having said that, it appears, Parham mentioned Matrix, but other evidence-validated approaches are motivational interviewing, which is really simple, contingency management, cognitive behavioral therapy, and community reinforcement approach. I won't get into any of those, but those are sort of the validated models. Number 2, I want to mention something Parham said that's a great time to mention it. He talked about anecdotal, and I wanted to comment on that, okay? And I think a lot of people might misunderstand that. I use the term anecdotal often. There's a colloquial use of the word, or layperson's use, and then there is academic or my world use of this, clinical science world. I use it in the technical sense. And what it means is it applies both your experience as the user or people out there, but it applies to our experience as clinician. And it could you can even say my clinical experience. And it is viewed as a form of evidence. It's just lowest on the tree of strength of evidence. So when Parham says anecdotal, it's heavy and it means quite a bit, but within that chain of strength of clinical scientific evidence, it's the lowest form. And what it usually does for somebody that is inclined to this kind of work is they look at that and say, well, Parham says it, that guy says it, that guy says it. Or Parham himself might be a researcher, so I'm going to put this into a case series. If that looks good, then it goes up into, double blind, cohort, all this stuff. So I just want to point that out. So when Parham says anecdotal, that's clinical evidence. Now I'm going to come back to one other thing. How I approach it. I've had quite a bit of success with this stuff, and I've had a couple of failures. In fact, I don't even call it a failure the way we approach it. There's a guy that we have, and my team's been trying to just get him in treatment for a year. That's, and the issue there is being open and receptive to a person. He won't even come down. He finally did come down. And interesting, I'm laughing, and if he's watching this, he's laughing because we have a great relationship. Yeah, he drove several hours, and finally he said, okay, I'm coming to treatment. And what he did is at the house every single day, he would drive back 4 hours to get some meth and then drive back to treatment. He's a wonderful guy, and I'm laughing because, like I said, I know him so well. And we eventually said, look, Henry, let's step back from this. We're here for you. Let's move forward. When someone does come in, one of the things I attempt to do is, like Parham said, hydration. By the way, methamphetamine use, one of the other acute effects is a thing called rhabdomyolysis, which will destroy and shut your kidneys down and potentially kill you. And a lot of that, a secondary issue of that is hydration. The primary issue is something else. So, I want to make sure they're hydrated. But the other thing I do is, depending if they had just been on a run or not, I just let them sleep. The body's telling if they want to. I just want to make sure they're hydrated. If they don't want to eat anything, I make sure they don't. I make sure everyone knows nobody died from not eating, but they died from not drinking. And I let them catch up with their sleep. And the other thing I attempt to do is what's called supportive clinical care, and in this case, supportive medication. The medication is not meant to treat methamphetamine abuse addiction, really, but the support of that medication, number one, I try to figure out if they are having psychosis. Many of these guys go without telling you. They're having conversations in their head for the last 3 months and have paranoia, and they're embarrassed. So I try to really tease that out, and then there's sleep medication and whatever else that's needed. I kind of supplement it with that. And then we initiate essentially what you do. In my own private practice, before I had this wonderful team and resources, what I would do, because there's another issue here, it's oftentimes polysubstance abuse nowadays, right? I get the opiates and I get the meth. And what I've done, and some of these guys are doing really great out there, just in the office outpatient. Okay, let's hit the opiates, get that under control. If we do that with maintenance medication, you're not off the hook. You get your meds once a week. You come in and you give me a urine. And this is where harm reduction comes in. If it's positive for meth, which you've already admitted, you don't get kicked out of practice. You have more things imposed on you. All right, you're not going to get your Suboxone or whatever it is for a month refill. You will be coming in every week. And I've had people do this. They come in every week and we explore the methamphetamine events that week. And by paying that very close, and then you soon realize they're not going to get in trouble, but by paying close attention to what happened, why they did it, really practicing both motivational interviewing and really mindfulness technique of meditating and getting their mind used to understanding how that event happens, we get there. I've gotten there many, many times with many, many people with pennies on the dollar at that point. I got a kick-ass team that really does a lot of this stuff now. But this is what I used to do. And just most recently, except for my buddy that I just described, the rest of the team does this beautifully. And one of them is Nicole. So that's what I do, Parham, which I think is in line with a lot of what you're describing.
Yeah, I mean, I didn't know you wanted me to get specific with it. With
you have to.
with the modalities, but I do echo the CBT, which is cognitive behavior therapy, which, you know, it believes that all human beings, we have our level of emotions, we have our thoughts, and we have our behaviors, and you can intervene and you can impact one of them and the other ones get impacted. Quick example for that. If I wake up in the morning and say, shit, today's Monday, I'm going to feel a certain way after that. I'm going to feel like, my shoulders are going to shrug. I'm not going to be excited, not be motivated. When I'm not excited, not motivated, my actions are going to follow. I'm going to be lazy. I'm going to procrastinate. And then when I'm lazy and procrastinate, it's going to make me think certain things and feel certain things. So it's like a perpetual cycle, a triangle that keeps continuing. So in treatment, you know, this happens with drug use all the time. If you learn how to intervene at the level of thoughts, change the types of thoughts you're having, what it's going to do is going to change the way that you feel. When you feel better, you tend to do better. When you do better, you're going to think better about yourself. And you can intervene at any one of those levels. So earlier when I was saying go out for a walk and it will change the way you feel, that will also change the way you think. And sometimes even at the level of emotions, go watch some YouTube videos of, like, you know, kittens or something that makes you laugh and smile. When you laugh, you'll start to feel a little bit better. You'll start to do a little bit better. So there's different ways to intervene. DBT is also really effective too, doctor, which DBT also gets into the mindfulness component, also gets into emotion regulation, which is very important when you have to learn how to self-regulate and manage your emotions, you know, especially with the stuff that you're talking about, with the anger, the communication, the interpersonal communication challenges that meth users have when they get off their drug. These are very important coping skills and very important therapeutic interventions and strategies that need to be learned in order to live a life without drugs and alcohol. You know, it makes it a lot easier to do it. So, if you wanted specifics, I can go specifics all day long with it. I just didn't know with our time.
I want so anything you give, it's a wonderful opportunity, not just for me to learn, but for the community out there as well. You approach it how you want. I love learning whatever you have to give and implementing in what I do. For example, I know what it is, obviously, but will you explain for those out there the difference between DBT and CBT? Will you do that for everyone out there?
Sure. So
go ahead, because we have an opportunity to have a professional here. So feed us a little bit, please.
So DBT is a dialectic behavior therapy. And one of the essence of DBT is, for example, someone says that life is either black and it's white. DBT at the core of it teaches you that sometimes life can be black and it can be white. So it helps you replace the ors of life. It helps you get from this polarized this or that life into this and that life, which this is huge for addictions, by the way, because it allows us to be okay in the gray area. So how do you get there? And that's 4 different interventions. So one is through mindfulness. So mindfulness is one of the components of DBT. Mindfulness could be a form of meditation. It could be a form of breathing. It could be a walking meditation. It could be being outside in nature and just becoming aware of your surroundings. It could be grabbing and holding and touching something in your hand to kind of get your sensory, to get a different feeling going on. DBT, by the way, is used very effectively also for personality disorders, such as borderline personality disorder. It is one of the evidence-based approaches for it. And then after that, it gets into interpersonal communication skills. Okay, so interpersonal communication skills is how you are able to communicate from yourself to the world. And we all know as addicts, alcoholics, people that struggle with addictions, communication is one of the biggest barriers to connection. Because 1, maybe you've never learned healthy, appropriate communication growing up. 2, maybe you have a hard time communicating what's inside to the outside world. And 3, it's like drugs and alcohol does what? It suppresses our ability to naturally communicate. So interpersonal communication becomes really important. And the next one is emotion regulation. So it's pretty much coping skills. It's finding out ways to be able to self-regulate your emotions, not regulate your emotions with Jack Daniels, not regulate your emotions with methamphetamines, not, regulate your emotions with addictive behaviors, if you will. And the very last one, I think, is distress tolerance is what it is. And it's the ability to be able to handle stress and to be able to effectively increase that without the need to escape and go use a substance. So if some days you were only able to experience a level 2 out of 10 and it was too much for you, it's how can we make that 2 go to a 4 or a 5 or a 6 without feeling overwhelmed, without feeling like all of your senses are about to kind of, you're about to lose yourself, without having to run away or to avoid, or without having to get angry and confront. And those are the 4 main components of dialectic behavior therapy. It's a wonderful thing. I mean, a simple search, you'd be able to find it, but it can be used individually. It can be used in a group setting. These days, I'm sure it could be used via telehealth also. There's a lot of good workbooks, worksheets that go with it, that there's homework assignments that you could actually use in conjunction with that type of therapy. But it's effective. I like it. There's a lot of good clinicians out there that use it.
Guys, so a lot of stuff Parham just talked about. I just was looking at some of the comments on TikTok on you talking. A lot of stuff that Parham's talked about. This is what we passively, the kinds of stuff that we discuss every week regarding a lot of these issues. Today, he's using, I guess, some big words, and maybe I may be, but it's really and please come on and ask whatever you're wondering about. Come on and ask. This information is gold, guys. And I'm gonna kind of push Parham. Whoever wants to get on and ask, and at some point here we'll get on here. Just so you guys know, I got to get out in an hour and 15 minutes this week and the next 3 weeks. But get on and ask, because this is you have a really badass guy explaining this stuff. Parham, it's kind of funny. Anytime I hear DBT dialect, because for some reason my mind goes to Hegel and Marx and dialectics of history, and I don't know why. To this day, it goes back to that. Just a little side note. Now, tell me this: length of time for this kind of thing, and this is critical because one of the things that happens with the substance abuse population, just like a lot of the personality disorder population, I just noticed someone in here talking about borderline, is they seem to see things in categoricals and black and white. The substance abuse population does the same. With the substance abuse population that is not leaning towards, personality disorder from the start, what that does is create hopelessness, because you don't see the 60,000 different options and shades of gray in between your choices or your perception of the world. So this is really important, and maybe you guys either want to go back and listen to what he said and come back here and ask questions. He's giving you some gold. Parham, tell me, is there any data on length of treatment? And then give us a little bit about CBT, and if you would, give us a little about mindfulness. And guys, don't put your questions, whether it's on the YouTube or here, just get on here and ask him. This is good stuff, and I'm forcing Parham to be a little bit technical just because. Go ahead, Parham.
Just because you can. No, I'm happy to do it. I really am, and we do appreciate when there's specific questions, because when you ask a question, when you come on with us, it actually allows us to create an answer that can a lot of people can apply to. But length of time, it's going to vary. I know that's not a question that people like to hear, but be wary of anybody that tells you that treatment in regards to healing is done in a 30 to 60 to 90 day period of time.
Thank you.
Right? Just be very wary of that. And I'm not saying that you can't make some effective progress in periods of time, but if you look at every single human being in the world, we're all individuals. We all have a different story. We all come from different backgrounds and upbringings. We've all experienced different pains, different losses, different challenges, different traumas in our life. We all get motivated and excited by different things. We're all inspired in different ways. We all have different current life circumstances and situations. So let's just, for example, if I get 2 meth users that come to treatment and both have been using methamphetamines for, let's just say, 5 years, and one of them also has a marriage that is in shambles, and one of them also has a child that they're struggling with, and one of them also has is lacking a job and going through some legal challenges, and I say, hey, the both treatment for these people is going to take 90 days. Well, that'd be a very, very that'd be a sad way to kind of tell somebody, to give them some hope for something that's not going to be effective. Because here's the thing, they have to resolve their life. They have to look at their life and resolve their life. And doctor says sometimes this stuff goes on for a long period of time. You know, and don't ever underestimate the value of having supportive, therapeutic, compassionate care around you for an extended period of time. And I'll tell you why. Because the greatest athletes in the world have coaches. The greatest professionals in the world have individuals that go intervene on their mindset. So there's nothing wrong with having the go see, talk to someone, work with someone, to look at your history, to look at your journey. It's a really valuable thing to do. So time frame, doctor, is that's for sure. And the second component of it, the CBT that you're talking about, like I said, it's cognitive behavior therapy. It's been around for a long period of time. Sometimes with some individuals, it's effective to use, and I'll tell you what the difference is here. So some people, they're always inside their mind. They're always inside their head. They're always inside their thoughts. And for those people that think as a drug of choice. So I've been on record telling some people that, hey, your first drug of choice, it wasn't alcohol, it wasn't weed, it wasn't opiates. It was actually your thoughts. It was your brain. It was the way that you started thinking and overanalyzing. Because guess what? When you think and overanalyze, you don't have to feel, right? When you're constantly thinking, you don't have to feel. I mean, they say overthinking, overanalyzing separates the body from the mind. And we know that, you know, some Western medicine tries to separate the body and the mind, and that's a very irresponsible thing to do. The body and the mind are connected at all times. So CBT allows for that connection to be felt. It allows for that connection to be experienced, to be utilized in the treatment episode. So you want to look at your thoughts, man. What you do is you literally sit down and you track and monitor your thoughts. You write them down. You write them down, and the goal for that is to be able to identify patterns of thinking, patterns of the way you view the world, patterns of the way you see the world, these cognitive distortions, they call them. Some of them are rooted in reality, and some of them are a byproduct of trying to figure out a world where it was too difficult to figure out, if you will. And these things happen like rationalization. It happens like depersonalization. There's a bunch of different cognitive distortions that we put into the world to be able to manage. So you identify all those things. And then you literally sit down in a group setting, you know, you share, you talk about your thoughts, and you're able to say, okay, what can I replace this thought with? How can I replace this thought? What would be a thought that would better serve me to think better, to feel better? And ultimately, this doesn't happen over time, because if you've been thinking a certain way for a long period of time, you're going to need to be able to have compassion for yourself. This is huge, by the way, in cognitive behavior therapy. Change doesn't happen overnight. You have to have compassion for the person that is trying to change. And there's gonna be some roadblocks, some setbacks. And then you want to really look into your emotions. I mean, people just think that we have a few basic emotions, and that might be true, but there's a wide range in all these emotions. And to be able to identify what emotions am I having on a regular basis? I mean, something as simple as having a calendar that you just write down a few of the emotions you experience on Monday, on Tuesday, on Wednesday, on Thursday, on Friday. And the goal is to bring insight and awareness into your emotional processes over the course of a week, over the course of a month, and to be able to intervene. Okay, what happens that I feel a certain way on a certain day? What happened over here? What happened over here? CBT provides a lot of insight. And lastly, you know, at the level of, you know, cognitive behavior therapy, I do believe that the physical body has to be intervened on. And that could be something as simple as moving. It could be something as simple as rest. It could be something as simple as nutrition. Because if you don't address that part, and all you do is address the thoughts and the feelings, I do believe that the holistic circle is not complete in terms of the potential of a human being to feel better.
Great. Yeah.
Yeah.
So, oh, go ahead. Were you continuing?
No, that's it, man. That's what I got.
Great. Thank you for that. I want to point out just a couple of things that came to mind as you were doing this. Everyone out there, people get, number one, people get a primary care doctor. Okay. And if you think your body needs a primary care doctor with regular checkups, uh, God knows, in this society and the constructs we've developed, both at the emotional, behavioral, cognitive levels, and at the institutional levels and family levels, I can tell you, we all need the same thing in terms of mental health. Why would we not want to do mental health hygiene? Number two, if you're dealing from this kind of stuff, methamphetamine abuse, and I would say all substance abuse, you need this even more in the long term. Number three, and this is becoming more difficult, and this is me saying this, and whether it's medical doctor, psychiatrist, psychologist, mental health, it's becoming more and more difficult to get somebody that really is qualified, even those of us that are licensed. Number four, this is how I view harm reduction, because a big part of this, and this is where the stigma of substance abuse has to just be shattered. A big part of this is the rapport and the relationship you build with me, with Parham, or with whoever you is. It has to be compassionate from my end. It has to be non-judgmental. It has to allow you, if it's the first place you've ever felt safe in your life, I have to unsterilize uh, uh, my environment for you. And more, we are moving to surgical, sterilized corporate practice of even traditional clinical medicine, which is the world I come from. But guys are out there, and that's my 2 cents on this. We have to break the stigma, because for some people, this might be multiple relapses. This might be multiple personal issues to deal with, a lot of shame. All of that, I argue, all of that, the first people that need to start fighting for this sub cohort of patients is the healthcare workers, the mental health workers, the clinicians, all the rules and regulations being placed on us. We have to be your number one advocates, do a professional, humane job with a very serious moral and ethical compass and a commitment to you as our patients. Our hands have to be freed as well. And in that way, we can empower you to get to all those places that Parham is discussing, and legitimize all the issues here, because it's hard to get there. And that's my 2 cents on that. Guys, both sides, TikTok, YouTube, get on here and ask questions. To the best of my old eyes can see, I see some really cool comments or thoughts or questions. Even if you want to share your experience, if you're in recovery, if you're in active use, if you are comfortable, get on there, challenge us. If you disagree with us, come on there and challenge us. If we missed something, come on there and let us know. Just get on there and talk to us. Parham, you want to read some of these comments and see if there's anything on
If
here?
you want, probably start from down and go up, because the beginning ones are just a bunch of people saying hi and checking in.
Okay.
Maybe start from the bottom and go back up.
You read them too.
Yeah, I'm reading them.
Yeah. Okay, Emma, you can. I'll look at your chat stuff. This is kind of a cool comment. Can I put this up from Sunshine?
Yeah, go for it. So it says, thank you both for taking the time to do this. I'm very intimidated by the idea of losing the security blanket that is my addiction. I even know how dumb that is, but it keeps me from getting help. You want to talk on it, or do you want me to talk on it?
Well, I mean, I'll be brief. Sunshine, there's nothing dumb about it because that is what addiction is. It's a security blanket for coping, for giving you that empty void that should have been meaning, the healthy development of the ego, the traumatic experiences that made it so you don't potentially develop in a way where you can have all those things. So there is nothing dumb about it. It is absolutely intimidating and scary. And that is the one leap you have to take. And you know what? When you take that leap, when you find the right healer, I'll use that general term. And again, please, this is me saying this, make sure they are know what they're doing and they're licensed. I mean, they're competent and they are compassionate. When you make that leap, you're going to see how easy it was relatively. I'm not saying it's easy and I'm not going to say, but nothing happens because you know what? Life is going to go on. Parham, please go ahead.
Yeah, I mean, I was going to say the exact same thing regarding that. Is not a dumb statement by any stretch of the imagination. Anybody on the side chat that has gone through addiction will understand that. I know I understand that. Doc professionally understands that because he sees it all the time. That is addiction. And here's the thing, addiction at some point in your life, it gave you the security that you needed and wanted but never had, and you got it out of the drug. However, now you're not that person anymore. You know, we evolve, life changes, we move forward in life. And if you've gotten to a point in your life, and I don't know if you're there yet, but if you've gotten to a point of your life that you aren't getting the same payoff that you used to once get from your drug, it is the responsible thing to do is to look at, say, hey, what else can I do in my life? You know, because everything ends. You know, life has chapters. What else can you do moving forward in life that's going to give you that sense of security? That's going to help you get a sense of self back. And that's the beauty and the what's possible and available in the recovery process. So it's all about holding on and letting go, right? When the pain of holding on becomes more, people tend to let go. That's the best thing I got for you. So it's not that I'm wishing pain upon you, but if that's where your life is headed with your addiction, then the beauty of letting go is gonna open up a whole world for you that is worth exploring.
Thank you. Yeah. Sunshine,
sure.
If I give you anything more, that's a great comment. We appreciate it. MI's staying back today, but MI's got so many great comments.
Doc, there's something, by the way, I've seen happen in this, and specifically with this, when people get off methamphetamines, I don't know if you've seen it, but I've seen them get on, and this person has left a lot of really good comments, by the way.
Yeah, right. That's why I put it up. They left
yeah, but I've seen this, and I don't know if you've seen it, is meth users get off meth, and without any type of psychiatrist or without any type of medical doctor, they go to places that they get Adderall at very high instant release dosages prescribed to them, 60, 90 milligrams, that kind of stuff. And I've seen the perpetual cycle of replacing methamphetamines with heavy use of Adderall to the point that it often leads them right back to the meth. So I don't know if you've seen that, but I've seen that professionally a lot.
And yeah, not only is that the case, in my deep dive this month in all stimulants, one of the first places I'm going because I'm on the psycho designer drugs right now. I did the plant cat. The next stop after designer drugs, I am going to go to amphetamines, their evolution, and their connect. And I will have a couple of episodes on the connection with attention deficit disorders, how they should be treated. And you are absolutely right. And amphetamine misuse, abuse, and diversion has been an issue in this country since the advent of this stuff in the early 30s. And people often think of, I'll just say this, people think opiate epidemic. The pharmaceutical industry's been inciting epidemics since the beginning of time in this country, including Merck and over 170 years ago. But with this drug that you're saying, these were some of the first epidemics with amphetamine class of medications. And you're right, this happens all the time. This is a great question, both at the neurotransmitter level, but also it's almost like, this is something you and I think, see all the time. And it has to do, with, give us some thoughts of how you deal with this kind of thing in general. What advice would you have back? Now,
Well, some of
let me just read it for those on TikTok that aren't on here. There's a comment that meth really makes it hard to find motivation afterwards for anything else in the world. I put that comment up, and Parham's going to give us some feedback on it in general.
Yeah, so I mean that's a very powerful statement too. I mean, and there's a lot of truth to it. So
Yeah.
I think it's a twofold response. One of it is just the fact that the brain is a deficit of dopamine and ability to achieve pleasure, the anhedonia, the inability to find pleasure in things that once were pleasurable. So some of it, the brain needs to jumpstart or kickstart again, right? So you have no control over the speed of that part of it. But the other one is, what can an individual do to increase their motivation? It's small, incremental, daily tasks. The smallest things, a little bit goes a long way. A little bit goes a long way. So maybe you don't have motivation to do something that's at a 9 or a 10, but can you find the motivation? And use the help of an accountability partner, somebody that has some motivation. You let them know, hey, I'm having a hard time getting motivated. Can I have your support or your help just to help you do the X, Y, or Z? The smallest little tasks in the positive direction builds this thing called the positive momentum at the level of mind, which actually does increase our psychological and emotional muscles to be able to access motivation. The more you do, the better you feel, the more motivated you become. It's a long journey, though. I keep talking about the 30-minute walk around the block. There's a reason, because it does something for the mind, it does something for the brain, it does something for the spirit, and something as simple as that. So motivation comes back. You always want to find, what is my why? What's my why of doing this? If you identify 3, 4, 5 reasons of why you're trying to do this, those become also your motivating factors of recovery. So it's being able to tap into those whys on a daily basis. Make sure you touch each of those whys one time in the day, because those are the things that you've stated are important to you. They're things that motivate you, to help you get out of bed. It could be family, it could be job, it could be career, it could be health, it could be goals, whatever the heck they are. Be able to identify your why and make sure that all the actions you take are in the direction of your whys. And I like this quote too. It's, remember that direction is more important than speed, right? So no pun intended with the word speed there, but direction is more important than speed. So as long as you're headed in the right direction, doesn't matter how fast you're going. The motivation will come as long as you head in the right direction.
Parham, when you were saying that, it brought something to mind, and I'm gonna really clarify this for all of us, the users, myself, mental health workers. Parham did something interesting, and he knows the answer, but I want to point it out for everybody out there, and he's being cautious in his words. He separated kind of the empirical, the medical, the clinical, with from a psychological perspective. And I want to make it clear to everybody out there, and this is really the root and base of why Parham I look at this in a global level, whether it's the individual, the family structure, that person's immediate environment, and I eventually kick it up to the social paradigms we operate in. It's all the same thing, guys. You know why? When Parham talks about spiritual, or what you can do is go for a walk or talk to somebody, there is no difference than the chemical events that, let's say a doctor would talk about. Because here's what's happening when he's telling you to do that. There's changes in your brain and in your architecture and in your connections, in plasticity, in what's called memory in a technical way, and your neurotransmitters. Now, we may not have formalized it yet by figuring out what it is and what the exact mechanism is. We may not have even found it, but most of this stuff by now we have shown. We know that psychological world, whatever terms you want to use, has a mirror and a correlate of things change. So It's not a small thing when he says, find one small task to get your motivation going, and then eventually the chemicals are going to come back. No, that small task that Parham is describing is what is going to speed the recovery. I just don't have the data to be able to say, if you do this task on this particular period of time, your probability of recovery is going to be increased by this particular percentage. That's all we don't have, but it is the same thing. And I want to really make that point. And what is the root of how I approach all of this, including compassion, because part of all of this is lack of compassion and connectedness, enemy. Anyway, so I just wanted to add that to what you said there, Parham, and thank you.
Thank you, man.
So let's thank you, MI. Let's see. This is kind of God. There's so many actually. Oh, there you got
Thank you, Randy. Maybe
uh,
one day. I'm still not taking new patients. This
and if Nicole's
is a good question.
Yeah, this is a good question. I saw this. Go ahead. Oh.
So the question says here, what if there is no reason to quit if they have tried meds before and they're only using meth because it's what's helping with motivation for daily life? Otherwise, they experience debilitating depression. So no one's ever saying to anybody to quit. You know, that's a personal choice. If you weigh the pros and cons of your life, and if you feel that you need to stop using the drug, people make that decision. Like I said, when the pain of holding on becomes too much, people tend to let go. However, if the drug use is the one that's creating the motivation and the lack of the drug use causes a debilitating depression, then it becomes really important to look at that element in that cycle, right? Because if a drug that causes all the things that Dr. B was talking about earlier with cardiovascular problems with the gut, problems in the mind, problems with blood, hair, skin, nails, the brain, you know, the mirroring, almost like a traumatic brain injury, you know, that kind of stuff is possibly used for motivation, then that doesn't look like a strong plan for long-term use. However, to each their own. That's really not my business. It's not me or Dr. B to tell you otherwise. However, if a person does want to get off that drug, we do have some information. And if that's what you choose to do with your life today, that's what you choose to do with your life today. And hopefully you're doing it in a way that's safe, that's not causing harm to others, that not causing too much harm to yourself to the least of its possibility for a dangerous drug. But to each their own. Like I said, both of us are really trained with harm reduction and compassion. So there are certain people that might have a visceral reaction to that, but for me, it's not at all, man. That's like I said, to each their own.
Me neither. And I'll add to this, and I'll add a little bit more meat on my kind of approach. You know, if you came into my office and said this to me, Gene, and said, but my partner or my buddy says I need to quit. I would have a couple of questions like, hey, was the depression going on before? Because if it wasn't, it's the meth that's causing it. But let's assume this is you started doing it to do that. My response to you would be, okay, is it possible for you to go the rest of your life using just a maintenance, small, safe dose to continue this way? Is it possible? Yes. Is it likely? No. What is likely, and we can term it in terms of abuse potential of this stuff, well, the likelihood, given the data that's out there, given the stressors that will come at you in life, let's say this is going great and tomorrow you get a divorce. Now you got even a more likely high probability of escalating the frequency and use of this stuff to a very dangerous level. So I would educate you on all of this and tell you, I'm always here, like Parham said, when you're ready, come back. I don't recommend you do this. And in my case, I would still send you to Parham. And if their organization absorbs someone actively using, but I think he's in a different setting. But I would send you to, Parham or whoever that is non-judgmental, like we're saying, and attempts to address this from a mental health perspective, if you choose to go that route. And I would still try and support it with some medication to get to the root of it. But that's what I would tell you. I would say, great, you're maintaining, but statistic-wise, it's unlikely. And I have to work in a world of data, and when there's no data, I feel it's my responsibility to tell you. And just so you guys all know, I'm going to say, a monkey could write you a prescription. I'm not a monkey. I'm a physician. And my first job is to educate you, my formal understanding of things. And sometimes I can be wrong, and you guys teach me many times, and give you options, and then support you, whatever the heck you choose to do. Unless if you tell me to, put a bullet in your head, then I would have to drop you as a patient. What I mean is that unless if you ask me to engage in something that is so grotesque with my professional ethics in the harm it's going to do you, I can't support you. But I need to educate you and document your reasoning and support you. So, we should be doing much more than writing your meds. Hope that helps, Gene. Anything else to add?
If you go all the way to the bottom, she wrote a follow-up that is actually a nice point, but I do want to talk about it. She just posted he or she, by the way, I don't know if it's a guy or girl.
This one?
Yeah, this one. Yeah, just at this point, it is a medication. How is it not? I will tell you this: that one thing that physicians do, and I'm not a physician. I don't write prescriptions, by the way. I'm a clinician. So, but I do know that when someone is getting medication, the physician, a good physician, is always going to sit down and evaluate the risks. Is going to evaluate the pros, the cons, the effect of the drug, the side effects of the drug, and I do know that methamphetamines isn't considered a classification of a medication. I understand that you're using it for medicative purposes, to increase your motivation. But I just want to clarify that the difference between an illicit drug like methamphetamines and medications that have been researched and studied and trialed and that kind of stuff, there is a distinction between the two.
Yeah, and in fact, what I just described is you are right. You are using it as a medication. So my job would be to educate you on the risk, benefit, and long-term potential of how this is going to go down the hole. So thanks for pointing this comment out. Yeah, you're right, Gene. It is being used as and again, is it mathematically possible where person X continues to do this at a super low dose without any harm for the entire life? It is possible. Is it likely? Very unlikely. And I have to operate in that world. And somebody like Carl Hart might disagree with me, but actually not on this issue, but in terms of recreational use to enhance somebody's life. And I categorically disagree with the position he takes for our current society and the structure. Hope that helps, Gene.
Yeah, and Gene, in closing, I do want to tell you this, that I personally can relate with you because I know that growing up, I used marijuana for self-medication of my anxiety. I later on used cocaine for self-medication of my depression. And I later on used alcohol for just self-medication of inability to regulate anything in life. So I have a lot of compassion for the fact that you're using the substance for self-medication. However, the same way that I came to the journey to find out there's other routes with lesser potential for abuse, misuse, addiction, depression, drug-induced depression, drug-induced psychosis. I came to this journey. So you are where you are, and that's totally okay. And it's I do appreciate the feedback and allowing us to kind of have that open discussion on that.
Okay.
By the way, you are at an hour and 19 minutes right now, by the way.
I am?
Yeah.
Wow. I have 3 or 4. Let's go 6 more minutes, Parham, since I lost track of time. This is actually this has been really good because we were really digging into this, and I feel bad because there's so much good stuff out there. This is Sunshine, which we talked to. 200 gas, all around other kind of stuff. Yeah, we got. I think we answered this issue. Let's see what a simple kind of girl says. And we never saw Nicole. Nicole, you want to pop in and give us a few words before departure. And I'm sorry, this month it's going to be an hour and 15 minutes. I was diagnosed with methamphetamine, was prescribed. I was able to work and have a successful life until measured. So this is what I was just describing, right? So what happens when people are maintaining on these high abuse potential xenobiotics, when an additional stress occurs, the crap just spirals out of control. This is one of the important things I always want to get out to people that advocate this kind of use. And I will get into this somewhere here, Parham, in this month on my series on YouTube, because I've made a few different comments about the ADHD. I think it's grossly underdiagnosed and undertreated. Yet at the same time, I make comments and say it is too many people are treated. It's over-treated, and this is bound to create confusion with people. But I did that on purpose because both statements are true. Here's what the issue is. It is grossly underdiagnosed, misdiagnosed, undertreated. So people are treated with other stuff. All kinds of crap happens. It's at the same time, it's our fault. The practitioners, they incorrectly treat it, diagnose it at times, and when they treat it, and this is my big criticism of us physicians. Look, if you're gonna put someone on a hardcore medication like this, you better have a very solid clinical course and plan, a very close follow-up, response to treatment with measurable outcomes and how it's affected their life, and be ready to adjust, decrease, increase, change with continuous measurement of how they're doing until that patient achieves a clinical measurable stability in what you're trying to do and safety in terms of abuse. And that's my position on stimulants as first line for this kind of disorder, which it is a great medication, but we suck at it.
I do know that this specific case right here, obviously I don't know this person, but in Orange County, we had a spike a few years back, if you remember, 5 years ago. And there was a lot of these, I don't want to call them pill mills, but there was a lot of doctors that were sitting in offices and they would have 20 or 30 people sitting in a waiting room. And the primary drugs of prescription were Adderall and benzodiazepine, specifically Xanax. And when someone like this would go there and have a breakdown, what they would do is just put them on a lot of Xanax to help with the anxiety that they're experiencing. And these poor people would just be on, 30 milligram Adderalls a day, whatever, 30 milligram Adderalls a day, plus a lot of benzos. And they're just managing their energy levels and their anxiety through these medications, which we've done so many talks on benzos together. You see the poor clinician and the poor physician that doesn't do a whole diagnosis and full clinical assessment of the human being. They're really setting these people up for disaster, and I don't know how this person ended up, but if that was the route which a lot of those doctors go about, instead of dealing with the major life event and rather kind of dealing it with medication, it sets people up for a lot of the things we heard in the past few weeks on our show.
So let me expand on what you just said real quick before I go. The problem was and is worse than that, because they do this. There's a cocktail, which I call it the pill mill cocktail. And as we speak, I keep every once in a while getting patients from a particular person's office, and I'm wondering how they're still practicing. The cocktail of the pill mills in Orange County, at least, are this. What you just said, both of those, high freaking doses. But there's more to it. They also add the Suboxone in there, and they also add steroids, right? High dose. It's an insane push and pull cocktail, and just rips these people apart. And there's one I get, and in fact, I actually sort of took over one of these alleged places, and I was highly criticized for doing it because everyone's like, A, you're nuts. B, what are you gonna do? All kinds of. But I took over one of these places, and it's worked out beautifully. That's and it's still going on, Parham. It's a very interesting situation.
Sad, man.
Yeah, it's tragic. Okay. God, we gotta cut this out. Parham, why don't you? TikTok, you guys gotta go over there and. I thought this was a great show. We didn't see anyone. I don't know if there's something wrong. We didn't even see Nicole. But Parham, you want to close up and tell them a little bit about whatever we're going to do next in the future? You do the closing here.
Yeah, no. So thank you, everyone. Normally this goes for about an hour and 45 minutes. This month we're going to be doing an hour and 15 minutes for personal reasons, but it's every Sunday at 1:45 p.m. Pacific Standard Time. You can go and watch all of our previous videos. We've done a collection at this point of really wonderful live streams. There's always a link available to anybody that wants to jump on and watch and come talk to us live. You can even come on without your video on and just your audio. If there's any specific topics you want, anything you want to hear about, feel free to just send them to us. Let us know what you guys want, and we will do our best to cover those. Me and Dr. B both look forward to this. We talked throughout the week talking about how excited we are for Sunday. So without you, this wouldn't make sense. So thank you for your support and participation. If you've never been on this channel, please subscribe to Dr. B's YouTube channel, hit the like button, make sure you get the alerts going on because he makes a lot of cool videos and we have a lot of good things coming towards you, So thank you for allowing us to be a part of your Sunday each and every single week.
Yeah, and same with Parham said, and the TikTok guys. Look, this is for all of you guys. It's the YouTube channel. The name of my Dr. B Addiction Recovery. Every Sunday we're on there live. We have a base topic we discuss. You can all come, get involved in the conversation. Jump on here. It's pretty easy to get on and talk to us. We want to answer any and all of your questions. This is for you guys. We're doing it to support you. As I said, the channel is a nonprofit, guys, and I'm going to repeat, me and Parham don't get paid for this hourly, and we are both basically buried in work. So it's for you guys, and we love doing it, so take advantage of it, guys. This is for TikTok and YouTube. So I'm going to say bye. Thanks again, everybody. Parham, should I... let me end the broadcast here. Guys, thanks so much for coming on.
Bye, guys.
Bye, guys.